All right. Good afternoon, everybody. I think let's go ahead and get started. Thank you for coming today. My name is Charles Codner. I'm one of the Department of Family and Geriatric Medicine faculty here. I have the honor of introducing Dr. Wexler, our speaker today. I wanted to welcome you to the James Stambaugh Lecture on Humanities and Medicine, sponsored by our department. And I just wanted to give you a quick introduction to Dr. Stambaugh and the purpose for this series. Dr. Stambaugh was an outstanding ophthalmologist in Lexington for many years, and he had served in the Korean War, which helped to develop his sense of compassion and the need to actually care for the patient as well as the illness, and contributed to his practice of embracing new technology while never losing sight of the medical and emotional and spiritual needs of his patients. During his later years of practice, he became increasingly interested in some of the ethical and societal and professional issues in medicine and how these impacted the welfare of individuals in need of care. The Stambaugh family has been kind enough to endow this lecture series to ensure that these ethical issues continue to be addressed and receive the attention that they deserve. And I'm happy to participate in this. Today's speaker is Dr. Richard Wexler. Dr. Wexler has had a remarkable career in shared decision making, and that's what he's going to talk to us about today. He's currently Chief Clinical Integration Officer with Healthwise Incorporated in Boston, and has designed a consultative practice to support organizations as they try to design and implement shared decision-making programs. He's board certified in internal medicine and gastroenterology and has done extensive work with patient decision aids, disease management systems, health policy development and implementation, hospital accreditation, and healthcare utilization. And he's also, I saw on his CV, a team leader for the Habitat for Humanity, and is going to talk to us about shared decision-making. Dr. Wexler.
Very lovely. Thank you for such a warm welcome. Can you hear me okay? Oh, good. It's such a big place. Well, thank you all for coming and for that kind introduction, and I want to thank the Stambaugh family for this wonderful endowment and the opportunity for me to come and talk about something near and dear to my heart, and to Dr. Harper for inviting me, and for all of you to come over lunch hour in what seems to be a beautiful spring day. I've come from Boston yesterday, and some of you may know we had an awful winter, so just to come here and see green grass and flowers and friendly people who smile at you, it's all very good. So thanks for that. I want to switch the slides around and then tell you what I'm going to talk about. Okay. Great. All righty. So I've entitled this Shared Decision Making, Not Your Ordinary Quality Improvement Initiative. And the reason I wanted to call my presentation that is because I'm aware of all the good things that we've been asking clinicians to do. And there are probably 600 quality initiatives we could choose from, and many of those fall to the plate of clinicians, and particularly in the primary care setting. And I think it's overwhelming. And we're doing that on top of implementing electronic health records and the challenge that that represents as well. So my heart goes out to you who are struggling with this. But I would put forth that shared decision making is quite different than managing hemoglobin A1C levels in people with diabetes or cholesterol levels in people with heart disease or trying to prevent heart disease. Shared decision making represents a fundamental change in the way patients and their clinicians interact. It's probably as fundamental a change as trying to implement an electronic health record, but in my mind, it's a lot more fun. So we've been fighting for shelf space, and at the end of the day, with all these other quality initiatives, at the end of the day, we all, if we believe in it, need to advocate for it and try to get our organizations, our communities, our leaders to embrace it and help create an environment, a context, where we can have a few minutes to talk with our patients about things that are important to them and make decisions together with them. So that's my introduction. This is my disclosure. As was mentioned, I work for a not-for-profit organization, Healthwise, that provides health information, decision support tools, and behavior change assistance. Now, in order to try and make this resonate with all of you, I'm going to ask that you stop and think about your own health or the health of family members or friends. And if you or they had made a decision, say about starting a prescription medicine that they may take for the rest of their lives, or having a surgical procedure. And if you have, and many people have, then I'll ask you to ponder whether, in fact, you were informed and involved during the decision-making process. Informed and involved. And that's really the foundation for shared decision-making, as you'll get to see. Now let's take a look at what we know about how well, learning objectives, sorry. So after this session, my hope is that you will fully endorse the concept of shared decision-making, promote it, and for those of you who are clinicians, that you will incorporate elements of shared decision-making into your clinical practice. You may already be doing that, maybe do a little bit more of that. That's the goal. So the outline is quite simple. I'm going to present the problem, and then offer a solution. Shared decision-making, you can imagine. So here's part of the problem statement. Are patients informed? This is a study that looked at patients who had undergone joint replacement surgery in the last 2 years. And through a series of expert interviews, we had identified 5 key facts that patients ought to know if they're going to be informed about joint replacement surgery. And this slide looks at the number of patients who got the answers correct to these very basic questions. So the question of how many people will get pain relief from their surgery, 28% were able to answer that correctly. Have a surgical complication, 46%. Have it last for at least 20 years, 15%. And how long it would take to return to normal activity, 29%. So we would call this making fateful decisions in the face of avoidable ignorance. And we can do better than that. And we have to figure out how to do better than that, despite the time pressure that we're all under during our visits with patients. Now I'll turn to the other side of the equation. Were they involved? And again, this is actual survey. This is a phone survey of patients who had undergone either prostate surgery in the green here for prostate cancer, localized prostate cancer, or had a stent, coronary artery stent, for stable angina. And the questions here are, did the doctor discuss the reasons for the intervention? And you can see that we did a good job at that, for both conditions, the prostate cancer and the coronary artery stenting. Did the doctor discuss the reasons not to have the surgery? Well, we have some fall off here, particularly around stent surgery. Again, remembering this is for stable angina for the clinicians in the audience. And not as well as we did on the 95%, even for surgery. And then any alternatives seriously discussed. And we know for prostate cancer, there's certainly active surveillance and radiation therapy in addition to surgical intervention. And only 2/3 of the time were alternatives discussed, and way less than that for coronary artery stenting for stable angina. And did the doctor ask about your preference, what you wanted after you had some information? You can see we're not doing so great there. So we see some room for improvement in both in terms of informing and involving patients. And if you ask that question specifically, were you involved as much as you wanted to be in decisions about your care and your treatment? And this is from the NHS, National Health System in the UK. This is a global problem we're talking about. And you see the percents responding definitely yes. So we're not making much improvement in the UK either in this area. And remember, the UK is the land that came up with the slogan, "No decision about me without me." And there's been a long push for patient involvement in decision making, but not much improvement over the years. So that's part of the problem statement, and here's the other part. Well, so what's the downside of not informing and involving patients in decisions about their body? And of course, there's an ethical, I go back to the Stamball lecture series concept of ethical issues. And let me just take a moment to say this is the ethical issue of autonomy. Patients having the right to have a say over what happens to them. And we have to balance that ethical issue with the ethical imperative to do good for people, beneficence. And it's not an easy balance sometimes. And we have the fiduciary responsibility of managing a finite series of resources. So again, I'm not suggesting that this is a simple problem to solve, but it is a problem worth solving. One of the things that suffers when providers are making decisions for patients is patient satisfaction. This is a recent study of patients who had undergone treatment decisions for lung or colorectal cancer. And the patients were asked to classify how the decisions about their treatment were made. Were they dominated by the physician? Was there some sharing, or was the patient having a prominent role in the decision making? And the findings of the study, and it's a large study with over 5,000 patients, is that when physician-dominated decision-making was the rule, that was associated with lower perceived quality of care and quality of communication. And that was even true for patients who, in their own preference about decision-making, said, I'd rather the provider make the decision. That subset was analyzed separately, and in that situation as well, when the physician dominated the decision-making, they felt that the quality of care was not as good. That's the perceived quality of care. So that goes along with patients really wanting to be informed and involved. Now, it's not surprising that patients underestimate the harms and overestimate the benefits of interventions, screening interventions, surgical interventions. This is another recent study from 2015 that looked at that in a large number of patients. It was a meta-analysis of multiple studies. And it's not surprising because we oversell in the profession, talking about the pros, not talking about the cons. Patients need hope. They're looking for some bright spots, and they need to put their faith in the people. So this is a consequence. But the downstream effects of this, if people don't really know what they're signing up for, and they're overestimating the benefits when they have a potential harm, they're going to be pretty dissatisfied. And we'll get to that as well. Now, remember when I had the earlier slide about coronary artery stenting and how informed and involved patients were for that? I'm going to go to another study. There have been a series of studies that combined many small studies or meta-analyses that looked at the benefit of coronary artery stenting and looking at what patients thought was the benefit. So this is looking at what patients thought was the benefit for stable angina. So 90% thought it would help them live longer. 88% thought it would help them prevent future heart attacks. 67% said it would help relieve symptoms, but only 1% said the only demonstrated benefit in this situation is to help relieve symptoms. And then if we look to the literature, we have had 61 trials, 25,000 plus patients showing that in stable angina, there is no evidence that these stents have an effect on death or myocardial infarction when compared to optimal medical treatment. So in essence, the evidence has been overruled. People are seeing the benefits through rose-colored glasses and are overestimating the value of these interventions. And we have a system, as you may well know, in the fee-for-service world that promotes doing rather than talking to patients. And that's one of our big challenges right now. Now let's turn to the concept of of trying to figure out what is important to patients. So even if they get the facts right, they have to interpret those in the context of what's important to them personally. And this is a study that looked at women. It involved women who had had breast cancer and their providers. And the providers and the women were asked to rank a number of goals and concerns, and we're looking at the top 3 goals. So what goals or concerns ranked in the top 3? And the providers said, well, 71% of the providers said keeping your breast would be a top 3 concern for women. 96% thought, well, living as long as possible would be a top 3 concern for the women. And so on. You see 40% looking natural without clothes. Avoid wearing a prosthesis. None said that would be a top concern. Yet doing what the doctor thinks best, I think it surprises me, but they sort of underestimated the impact. But we'll come back to that because that's quite important. Now we'll compare that to how the women rank these issues as top 3 goals and concerns. And you can see that there's quite a difference. Only 7% rank keeping your breast as a top 3 concern. And this is while medicine had gone into thinking, breast-conserving surgery should be the rule for whenever it's possible, and organizations were advertising the percentages of surgery that were breast-conserving surgery, assuming that this was what women would naturally want. But they got it wrong for at least a significant proportion of women. And you can go on down. I mean, this 59%, this is the quality of life versus the length of life issue, and looking natural without clothes, and so on down. But doing what doctor thinks best, 86% of the patients. So here's the catch, is if we get it wrong as clinicians, patients may well follow through with our recommendation, but it may not be the right decision for them. And that creates an issue. And we are now calling that the silent misdiagnosis of patient preferences. So many doctors aspire to excellence in diagnosing disease, but far fewer aspire to the same standards of excellence in diagnosing what patients want. And there is part of our problem. So you might ask, well, why don't patients just speak up and tell me what they want? And I don't know if you go back and you think about your own encounters, even as physicians or clinicians, the reluctance to speak up and express what's important to you, particularly if it seems to be going against the tide of the conversation. So this is a study that was done in Palo Alto, Silicon Valley, very high SES, socioeconomic status patients in focus groups. And the themes that emerged were that the patients feel that many physicians are authoritarian. They feel compelled to conform to socially sanctioned roles, which are passive roles. And then they go and work to fill in the information they don't get on their own, which creates a real time issue for us in the office who have to go through the information that they get, and it may not be very good or balanced information. And the patients feel the need to bring social support to the consultation. They need somebody to help stand up for them. And then here's a quote from one of the patients in the focus group. If I were to do that, and we're talking about speaking up and saying what's important to you and shared decision making, if I were to do that, I would think, is the guy going to be pissed at me? Is it going to come out in some way that's going to lower the quality of my treatment? This is very dark, and I don't know how generalizable this is. It does remind me of an old Seinfeld episode that some of you may have seen, where Elaine was labeled as a bad patient, and she couldn't escape that. It followed her from one doc to the next because the records went with it. Authoritarian physicians and patients' fear of being labeled difficult among key obstacles to shared decision making. And this is getting more and more press. This is a recent study, a recent story in a health policy journal called Health Affairs. And it details the sad story of a man who went to the emergency room and had a fracture of his forearm and had an internal fixation device, screws and rods put in. It was the recommended treatment. He was uncomfortable asking, well, how many of these have you done? What's the track record of this? How does this compare to a cast or more conservative therapy? And unfortunately, the fracture became infected. There was a foreign body there. He had multiple operations, and now he has decision regret. It was the wrong treatment choice for him. Now, we cannot prevent complications. But if we arrive through decisions, through a good process, and complications occur with fully informed patients, I think we've done the best that we can. So this is not about trying 100% to prevent complications. It's just to keep patients informed so they know what they're signing up for. And they have more realistic expectations. So I'm going to frame this in our most provocative way that we can for point of emphasis. And in the world of quality improvement, we have often thought that wrong site surgery, operating on the wrong limb, was the worst kind of mistake we could make. And it always creates a big uproar, as well it should, in the news, what have you. And there's been a great deal around the patient safety movement now to prevent that. And those of you in practice know, I think there are all sorts of safeguards that are being put into place. But the provocative question is, how do we describe operating on a patient who would say no to surgery if the alternatives, risks, and benefits were well understood? And we can call that wrong patient surgery. And it's bigger than the wrong site surgery because we believe it happens far more often. Unknowing to us as clinicians, nobody would ever want to do this, but because we are not having the opportunity or not taking the opportunity or finding the time to talk with patients, even when we're supposed to have an informed consent process, that's way more than signing a form. We're not able to do that, or we're not doing that. And we believe there's a significant problem with wrong patient surgery. So, here's the summary of the problem. Patients making decisions in the face of avoidable ignorance, and clinicians doing less than an optimal job diagnosing patient preferences leads to poor decision quality. And then we have decision regret, we have more malpractice, and we have dissatisfied patients. And at the end of the day, we as clinicians don't feel that we're doing as good a job as we can if we understand that this really happens, or accepting that it happens. So I'm going to move on to the second part of the presentation now. This painting the picture of the problem is meant to help engage you and think, yes, this is a problem worth solving. And let me say that I think this is not happening overnight. Our foundation, the Informed Medical Decisions Foundation, was started 25 years ago working on this problem. And we're chipping away at it. But our hope is that we are actually seeing more traction right now, and that all of you, as I mentioned in the learning objectives, will have a good name for what we're talking about, and to the extent that you can, whether you be a patient or a provider or a policymaker or a public health provider, will get behind this banner and try and promote this as it competes with the 601 other good things to do, and say this is really more fundamental and we need to put our energy and our voice behind this. So there are many definitions of shared decision making. This one I like. It's the process of interacting with patients who wish to be involved in arriving at an informed, values-based choice among two or more medically reasonable alternatives. So it's interacting, and I didn't highlight medically reasonable alternatives, but I'll get to that. So by informed, we mean, first of all, you do have a choice. You don't have to do this, and actually the choice may involve the alternatives, which may include doing nothing, too. And then you understand what your choices, the options are, and you understand what the benefits and the risks of those options are. And values-based, we could distill the essence of that to something quite simple. All of this information about benefits and risks is interpreted through a personal lens. That lens of a patient that is shaped by what's important to them, their goals, their concerns, their life circumstances. And two people with the same clinical situation, but different lenses through which they see that information, should be entitled to make different decisions about their treatment. The process of interacting is the bidirectional flow of information, where the clinician is the expert of the options and the risks and the benefits, and the patient is the expert on the patient, or the person. And this is what we call a shared decision-making conversation. And it can be done over a number of visits. It can be done with a number of different people on the clinical team. So it doesn't have to occur at one point in time. It often will involve family members as well to help clarify what's important, to help talk through the life circumstances. Now, you need not worry that this will encumber every decision in medicine. So we have a somewhat arbitrary yet helpful distinction of types of medical care that I wanted to bring out today. One we call effective care. And in effective care, we have a very strong evidence base that this helps people. The benefit to harm ratio is really high. And in our responsibility of beneficence, our goal is to try and increase the uptake. And there are quite a number of our interventions in medicine that are like that. But there are also a significant number of tests and treatment that would fall into the category of preference-sensitive care. And whereas effective care, the sweet spot for that was motivational interviewing to increase the uptake, here for preference-sensitive care, it's really where we focus on shared decision-making. So the evidence supports different approaches. The treatment or testing options involve significant trade-offs, and that here personal values and preferences and life circumstances should drive the decisions. I'm going to give you some examples of types of preference-sensitive care, okay? So one is a situation where you have similar benefits but different risks. And in managing a ruptured Achilles tendon, are there any orthopedic surgeons in the audience? Probably not, right? Okay, so I'll be less likely to be called out on this, but as I understand it, if you rupture your Achilles tendon, you can have a cast put on, it's immobilized, and the tendon has a way to join together and knit itself back. But you have to wear the cast for quite a long period of time, and that has its own impact. And you can contrast to a surgical repair where it's sewed together. You recover more quickly, but there's a greater risk of infection. So similar benefits, different risks, and different ways of deciding what's important. If you don't mind wearing a cast for a while and you're risk averse for the infection, well, you ought to probably end up getting a cast. Different benefits and different risks. So surgery versus medical management for knee osteoarthritis. We know that joint replacement for advanced osteoarthritis of the knee gives better pain relief, but it has more risk and there's a long period of recovery. And some people may not want to take that risk or be able to endure the recovery or pay the out-of-pocket expense. And they may be happier walking with a cane and really focusing on losing weight, whereas others, that may not be the appropriate approach. And then the last category is uncertain benefits and certain risks. We know that a lot of medicine is really unproven. So a lot of people will take a chance that it might work for them in the face of incomplete evidence at best. But others would only really want to try something if it's tried and proven and true. So PSA testing is one that I use for this example. There's been a lot of debate as to whether it saves lives from prostate cancer death, and it may have a small effect. The latest trials would suggest, but it has definite risks. Some people will say, you know, I want to do everything possible to make sure that I don't die of cancer. So I want to know about this, even if it involves a false alarm, even if it involves the risk of biopsy, even if it involves treatment of a cancer that might otherwise have been an innocent bystander as I lived out my life and died from something else. So you can see how people could come up with very different decisions about whether they want to be tested. And this is a hot topic right now because the whole issue of screening tests is being reconsidered at the same time that CMS Medicare has just offered coverage for lung cancer screening in high-risk patients with the use of decision aids and promoting shared decision-making around whether or not to be screened. Now, part of the relief is that you don't have to do this for every decision. And another part of the relief is that there are some really good tools to help with this. And if they're properly implemented, it can have a big time-saving and increased efficiency effect. Patient decision aids. So these are tools to facilitate shared decision-making conversations. They're a form of patient education, but a very specific form. And the highlighted or the red areas represent where they're different. So they present information organized around specific decisions. So the information is structured to help you decide. They strive to keep the information accessible and balanced. I want to mention that because there is a whole science about how to communicate risk. And if good communication techniques are used, people can understand risk. And I'll show you some evidence to that. And keeping the evidence balanced. So this is a key issue. It's very easy to unbalance the information with a nod or a change in intonation in your voice or a shrug of your shoulders in a visit. So by giving this in a very defined experience through watching a decision aid, these can be videos with booklets, they can be web applications, they can be paper, but doing it in a neutral environment may make it less likely that that bias will creep in as the information has been presented. Engaging viewers with real patient stories. Part of the goal of this is to help you anticipate alternate futures. So Madison Avenue does this all the time through advertising. They want us to think that we're going to be glamorous with a watch or a car. Pharmaceuticals do this all the time in their advertising. But we're trying to help patients in a similar clinical situation imagine what life would be like with option A versus option B. And sometimes patient stories, if they're done well, can really help you imagine that alternate future. And this last point, they really are meant to promote the concept of shared decision-making rather than here's the information, sort of a consumer model, and now you decide and tell your doctor what you want. So decision aids are tools, and they can help promote shared decision-making and make it much more efficient, particularly if you use them outside of a visit where the routine exchange of information that becomes quite tiresome to do as a clinician and time-consuming and very precious time that you have together, like in the flipped classroom in the Khan Academy. You can do the pre-visit learning and then come in for the problem-solving or the decision-making around what you actually want to do. And that doesn't, as I may have mentioned, have to be just with clinicians. It can be with any member of the care team, and we're seeing growing examples of that being non-clinician members of the care team with special training. So these have been studied up the wazoo, I have to say. I mean, probably more than many other, or almost any other clinical intervention. The Cochrane review of decision aids now summarizes 115 randomized controlled trials, sort of the highest standard of evidence about what the use of decision aids can accomplish. And we know that decision aids increase patient knowledge, patient involvement in the decision-making process, the proportion of patients with accurate risk perceptions, so they understand what they're signing up for, and the consistency between what a patient decides and what they state is important to them, so value concordance. All of this leads up to the conclusion of better decision quality. They decrease the risk of patients feeling uninformed or unclear about their personal values. That's decision conflict and regret. They decrease the proportion of patients who remain undecided, and they interestingly and intriguingly decrease the major elective surgery rates in favor of more conservative options. And this has been translated into saving of dollars. And so as we know, we have this huge problem with the cost trend. There's a great temptation to sell this ethical imperative of shared decision-making as a dollar savings. And we're reluctant to do that because I think the evidence is still light about that. There are some problems with baseline and duration of follow-up, and including the cost of alternate therapies in this. So we tend not to push this too much, but it's gotten the attention of a lot of policymakers, and that's why I think one of the reasons shared decision-making is incorporated in a lot of new healthcare reform. I'm going to give you a few examples of what we found in a learning collaborative that I was fortunate enough to facilitate while at the Informed Medical Decision Foundation. And this is in primary care settings. And this is meant to represent the groups around the country that we worked with. We asked patients questions about a number of questions, but one question we asked is, how important is it for doctors to give you decision aids like you received as part of this learning collaborative? And here's the rating by different cohorts or different segments of the population. And you can see that they really appreciate this. We know patients want to be informed and involved. They're seeking information on their own. If we're able to manage the information they get, make sure it's high quality information, this is a way to save some time and do some good, and patients will really like it and be satisfied, I think. This is the stated role preference in decision-making by our group of patients in our learning collaborative. And you see the N all the way to the right there. We've got a big group now. This is over 3,500 return surveys. And you can see that patients want to be involved, regardless of age, education, and gender. Now, from the same group, I want to review a few slides, just 2 slides, on the intention to have a test done or a surgery. We didn't actually get data about whether they actually had the surgery, but it's a survey of patients, and did they intend to have the surgery. And they were asked in this slide about colorectal cancer screening, and in this around PSA testing for prostate cancer screening. And this was before viewing a decision aid, their intention, and after viewing a decision aid, their intention. And you can see this is the intention to be screened, not being screened, and the unsure or not sure, same in this. So to make this a little bit easier, and I think the best way to explain it is to look at the not sure, because that's where the use of decision aids have the greatest effect. They help people decide based upon their evidence and their own goals. And you can see that the unsures decrease, and for colorectal cancer screening, they move in favor of increased screening. The decision aids let the information, the evidence, speak for itself. Whereas in PSA testing, there's a similar decrease in the unsure, but it moves to not being screened because the story is not as compelling as we understand the evidence. Now, this is from that same group, the same format, and this is about having hip or knee replacement surgery. So you see it's a smaller number, but still pretty significant number. Same format. undecided decreasing, and moving towards the greatest increases in non-surgery. And similarly for knee, undecided decreasing, going to non-surgery. And oftentimes the decision aids, if they really lay out the full range of options, people realize, well, gee, I haven't tried this yet. Before taking the risk of that, I might as well try something that's less risky and less expensive, especially now with cost sharing being the way it is. So I also want to dispel this concept that not everybody can learn from these. And what we did in this was looked at the decision aid exposure. How much did the patient say they had watched or read? And these were DVDs and booklets. As I mentioned, they come in different forms, but we had a DVD and booklet format. And they were categorized into low, medium, and high exposure. And then we had knowledge scores, because in the surveys, like in the earlier slides about joint replacement, how many got those answers correct? We had experts develop a few key questions, facts that we thought every patient should know. And you can see that this is what we would call a dose response curve. So the more that the patients reported viewing, the higher scores that they got. And in the 65 plus age, they had the greatest score gain. So carefully constructed decision aids can help patients understand the risks and the benefits of different treatment options. And we've done similar studies with different levels of education and numeracy scores. So we believe that if you use well-developed tools, they will be effective in informing patients. Now let's take a moment to look at the provider reaction to the use of decision aids. Again, in the same group. This is a harder survey to do. Surveying providers is hard. Everybody is so busy, and trying to time it to a specific visit is not so simple. So our number here is only 75. So take this with a grain of salt, but I'm going to follow it with another study. And here we were asking providers to compare the visit that they had with patients, those who had not had decision aids compared to those who had had decision aids prior to the visit. So comparing to those who didn't view a decision aid, 61% of the providers said that using decision aids had about no effect on the length of the visit. We're concerned that if we involve patients, they're going to come in with 101 questions. It's going to take too long. But if you implement it well, they're saying 61 said no change in the duration of the visit, and 28 said it was actually shorter. And then if you look at the quality of the visit, 72% saying it was a better quality, and only 3% for some reason said it was worse. By better, I think it meant that the questions were more appropriate. They felt that they had a more meaningful discussion, and I have to believe that high quality visits translates to more joy in medicine, and we've undervalued the provider experience. In the triple aim, the patient experience is appropriately emphasized. But if we don't have good provider experiences, well, I think we're going to be in trouble as a system. So this is interesting to us. Now, this is a similar study looking at provider perception of the visit for patients who had, in this situation, they had a decision aid group that had seen a decision aid and had the opportunity to talk to a health coach versus the usual material that they got. And the health coach in this situation was a college graduate who was aspiring to go to medical school. And they were doing this as an elective. And so it was fortunate enough that it did not cost any more to the provider team to engage the expertise of these coaches who were specially trained. And now we've seen this happen, similar experience of using health coaches, lay health coaches in a number of settings, not only in the US, but in other countries as well. And if you look at this, the decision aid group, the percentage of patients where a decision was reached in the first visit, which is very efficient from an orthopedic surgeon's perspective, is higher than in the control group. The percentage who chose a surgical option here did not differ, which was reassuring in a fee-for-service world. The question appropriateness on a scale of 1 to 10 was higher, so patients asked better, more informed questions, I should say. The overall visit satisfaction from a provider perspective was higher, and the time with the surgeon was the same. So we're getting preliminary evidence, hard to get this, to say that not only do patients like it, they benefit from it, but actually the providers like it. So there's a good reason now, I think, to build the case that we need to advocate for this within our systems. And I don't want to suggest that it's going to be easy. I don't know if you can all read this from the back of the room, so I will read it for you. Doctor, I want to choose how I'm treated. And the doctor says, you're not just ill, you're deluded. And that was a comic with an element of truth not so long ago. And now this is from the British Medical Journal, Embracing the Patient Partnership. And the first description of shared decision-making suggested that it takes 2 to tango. So this is a tango, and you can figure out who's the doctor and who's the patient. I'll let that be up to you. But what you can't see from the back of the room is the date of this, 1999. Okay, so I mentioned we've been at this for 25 years. We're pleased to see this in a prestigious journal like the British Medical Journal. It's been very active in promoting the role of patients. But we need to make room for the importance of this quality initiative and I think build the infrastructure both in terms of the technology to easily deliver decision aids through the dreaded electronic health record, but to make it a single click, leveraging the internet, though not everybody has access, but that's the direction we're moving into. So providers can do one click. It shows up in the mailbox. Patients can interact with the decision aid. Their interaction can be captured. It can go back into the electronic health record. Here's what I'm thinking about doing. Here's what I don't know. Here are my answers that I got wrong. Here are the questions that I have for you. And that can become the scaffolding for a shared decision-making conversation that can be done efficiently by anybody well-trained on the clinical team. So the concept is, let's not have to be as overwhelming as it might seem, because we're not having to do it with all decisions. We have a team and we can leverage technology, and we know there's an appetite for this. Now, I'm going to close with just 2 more slides. We've broken it down into 6 steps, shared decision-making, so this can be a practical framework. It will not be linear in your conversations. It will be much more organic. But it's important to let this serve as a bit of a checklist. So inviting the patient to participate. We've talked already about why patients are reluctant to speak up. That invitation goes a long way to letting people know that their voice is important, and I will listen to you as a member of the clinical team. Presenting the options and the risks and the benefits. Well, good decision aids can help you do that. It's so hard to know the numbers. We're reluctant to admit that sometimes, but we have tools that can help us with that. The discussion to help the patient understand, well, you know, how important is it that I gain this function? How important is it for me to know that I did everything to prevent getting a cancer? These will vary from patient to patient. Facilitate deliberation and decision-making. Do you have the information you need? There is no rush to make this decision. You can go home and you can think about it, and you can call us up and let us know what you want to do. Oh, do you want to talk to someone in your family? Yeah, you can do that too. And here's some information. Maybe I didn't give it to you before. Now you have it, and it will help you. So that deliberation process, what else do you need to make this a decision? What is the hardest part of making this decision for you? And then once the decision is made, acting upon it because without that, then all this work goes for naught. So this is an outline of how one might approach it, a checklist. And I think if we started with just this part of it, we would change the face of medicine, inviting the patient to be part of the decision-making process. I believe that comes naturally to a number of people, but it doesn't come naturally to everybody. And it just takes a moment to do that invitation. And then what will follow, if you're curious about the patient and you do the best you can with the information you have about the numbers, but you try and think about using numbers and covering the landscape of the options, you'll be off to the races. And I chose this, and I'm hoping that you will recognize where this photo is taken from, because I know it's, I came from Baltimore, so I do want to emphasize that there's another race in Baltimore. I don't think that bourbon is as big a part of that race, so I don't want to detract from what's coming up in 2 weeks or so. So you'll be off to the races, and with that I'm going to stop and thank you very much for your attention and hope that it's been helpful to you. Thank you. I think we have time for comments or questions, so please, I know we have others who have thought a lot about this in the audience.
I have one question about patient preferences and the idea that patient preferences aren't necessarily stable, rather they're more often revealed, and how patient decision aids sort of play a role in constructing patients' preferences.
That last part of the question, how patients' decision aids
Play a role in constructing the patient's preferences.
Yeah. Well, so did everybody hear the question? I'll repeat it by nature. So preferences are often not stable. They change over time. And how does that impact this schematic of decision making? And how do decision aids promote the construction of patient preferences? So we know they're not stable over time. It's an important point, but decisions occur at a point in time, and so we do the best that we can with this. I don't know that there's a magic answer to try to deal with the changing over time of the preferences. Decision aids have a number of ways, and their different decision aids have different ways of constructing the preferences. Some have preference sorters, which would say, well, you know, how important is it for you to avoid the risk of surgery? How important is it for you to avoid a long recovery time? How important is it for you to get relief from your pain so you can resume normal activities? And they rank it on a scale of 1 to 10. And some have sliders. Some actually tote those up and then suggest, like in Good Housekeeping, if this is what you want, or rather Consumer Reports, you know, this would be a good decision. I don't think the toting is such a good idea because the weighing of the different preferences is very difficult to do, and there may be many important preferences that weren't included in the preference slider. But so that's one way. Another way is by just doing videos and having people say, you know, I didn't want to be laid up and I was really worried about that. Or, you know, with these front-end deductibles right now, and I really have to worry. I don't have that much sick time anymore, and I don't want to break the bank with this right yet, so I'd like to try something else. To actually have people say that gives people permission to raise that as an important consideration. That's something that we're working on, trying to figure out how to better do that. So good question. Thank you. Yes, please.
You talk about avoidable ignorance. So if you're describing decision support, I can imagine how you can get on that learning curve. You're talking about decisions support in the context of perhaps a chronically ill individual. I mean, the learning curve just seems to me that it would be too steep for the patient to get over to help make decisions in a complex environment.
Well, your question about the question is about dealing with the complexity of patients with multiple comorbidities or complex illnesses, and how do we sort through that, and what sorts of support might we bring that through lay personnel or the care navigator that could be the primary care clinician or somebody else on the team. And let me stop and say that in shared decision making for multiple chronic conditions, it's overwhelming for patients to know where to start in the world of self-management. And so there's a real opportunity to use shared decision making to help decide what are we going to do first. And I think that the care coordinators or care managers embedded in the care team working with the primary care physicians can be helpful at that. In the care coordination also, we talked a bit earlier, I did with somebody here, I'm intrigued by the idea of the care coordinators in advance of making a referral to a specialty care provider, say around joint replacement surgery in a patient with diabetes who's at higher risk, to give them an opportunity to view a decision aid about this prior to the specialty visit and say, oh, do I really want to go through with this, or is there something else that I might want to try? It gives them a chance, as I say, to dip their toe in the water before jumping into the swift current of specialty care right now. So I think there's an opportunity to use shared decision making to where to start, to use members of the team, and the hard thing is finding time to have the conversation about a single condition. And I got a big dose of that yesterday, and it's gotten more in our discussions with some of the faculty. And it's gotten more complicated with the front-end deductibles, where patients with limited resources have only, they want to get everything done with one copay, and there's just not enough time. So this giving information outside of the visit may be a really important component of it. So I hope that answered your question. It's a good one. Yeah. Please.
You talked some about using any location and and as a first-year medical student, we learned a lot about that. But I was wondering if you had an opinion about if there's ever room for you to give your bias to your patient when you're trying to make decisions, they ask for it.
Yeah. So the question is, can the clinician make a suggestion about what the patient might do? And I think definitely yes. And if I were to be asked that question, I would say I'm happy to make a suggestion. But first, tell me a little bit more about you or what's important so I can be sure the suggestion takes who you are into account. I don't want to quibble about who throws the first suggestion on the table. It's a collaborative negotiation, really. And I certainly don't want to disempower clinicians by saying you cannot offer suggestions. But we could take that little step and say, make sure I understand what's important to you before I make the suggestion. Good questions, all good questions.
I find myself called upon often when patients come in and they have seen a surgeon who's recommending surgery, or they've been to the emergency room that recommends that they get a referral, and they are ambivalent about it, or they come in and say, I want to take your opinion first. And then we have to go through this process where it's already been kind of preloaded towards something happening. And I just wondering, have you seen anything about the patient's reaction to getting conflicting advice? I always tell them I hate to give conflicting advice, but I sometimes feel obligated to do so as I sort through these issues with them.
Yeah. So the question is, how do you manage patient expectations when somebody else has already potentially suggested that you need to see a specialist about this care in the primary care, but the patient, for whatever reason, wants to double check with you as a primary care clinician? Well, I think they've given you an opening to disagree with that suggestion, or at least to make the referral a shared decision between you and the patient. And I believe that there is an opportunity to develop systems that support this And even in the primary care setting, we've worked with groups to try to promote what we call a provisional referral. So you put it into the system once, but it has to be activated. And you would say to the patient, now, a referral might be right for you, but before we make a final decision about that, I would like you to watch this decision aid and then opt in to the referral. Either way you decide is fine with me, but I want to make sure that you're ready, and if you are ready for the referral, that you have all the information you need when you see the specialist. I believe, and I'm hopeful, that one of the good things that electronic health records will do is to clean up the referral process. It is such a mess now. I mean, it used to be in my days, I'm getting older, when a referral was made, we had a discussion about the scope of the referral. Is this for diagnosis, or is this diagnosis and ongoing treatment? And there was communication back. I was a gastroenterologist. I always wrote a letter back to the primary care doctors and stuff. But that's so broken right now. So to the extent that we can fix the referral process and build into the referral process a shared decision-making experience, and maybe with this opt-in option, I think it would be helpful. And you would need two options. You would need the definite referral. We've already decided this is good, do this. It's a joint decision. Or this is a provisional referral. I want you to opt into it. Well, good questions. And I know this is a tall order, but I do believe it's achievable. And I believe it's achieved in other countries. And I believe in our new generation of clinicians are open to it naturally, by and large. And I believe there's a growing voice of patients that are demanding it. And if patients will vote with their feet and support those clinicians who involve them in meaningful ways in decisions about their own body, that those clinicians will be rewarded in the joy of what they're doing and in other ways that make financial sense. So I remain optimistic despite working 25 years at this. My hope gets passed on to the next generation to a bit, but we make slow progress, and I'm grateful for that. So thank you very much for your attention, and I enjoyed talking with you. I'm going to walk down the steps. Yeah, I'm good. Oh, I got to leave this here. I've been taking cabs all around.